All right, so let's start tackling where our superficial hot and cold is. We'll tackle this today as well as Tuesday, and then maybe we'll move on Thursday. Yeah. At least probably closer to 30, 35. Yeah. Yep. So temperature regulation is regulated by the hypothalamus. That's what controls our internal body temperature. So if we're cold, we could shiver to try to generate more heat. We can sweat to get rid of heat if we're too hot. Sometimes the body can change in circulation. So if we were to walk out, it's really warm out today, but yesterday when it was snowing in different parts, when we walk outside in just a t-shirt, how come all of our skin turns bright pink? All the body's doing is saying, hey, this is cold, send more blood flow, blood's warmer, this will heat up the tissue and make sure that's not a problem. So that's how the body regulates its, broadly speaking. So different Fahrenheit versus Celsius conversions. The tough thing about some of our textbooks is it tells you a temperature in one unit and you got to figure out the other. What are you most comfortable with? You're most, yeah. So we do have a couple of examples there. Beach weather being 86 degrees Fahrenheit, 30 degrees Celsius. Some formulas if you wanted to do conversions. So what are some mechanisms of heat exchange? Well, we have direct contact, which is conduction heat. Convection, movement of air, matter, liquid. Who's got a convection oven? What's the difference between a convection oven and a regular one? Just that. Yeah, and how does it distribute that heat? With air. Yeah, it's all it is. I mean, my stove has both convection and non-convection options, and yeah, all it is just a little fan goes ting, ting, and just circles the air better. Yeah. So radiation through air from warm to cold. I think we can see this sometimes. I've got a wood stove in my house, and when you look at it, you can see all the heat lines over top of it. Sometimes you can see that on really hot days in the pavement. You can see those heat lines. So that's radiation. Conversion, energy being transformed into heat. So we'll look at that with ultrasound. And then evaporation, the sweating, so turning liquid to gas. We also have spray and stretch. That's fun. Worthless, but fun. So that's another way we could conduct heat. Few different examples we have for our superficial heat exchange. Hot packs we've talked about a little bit already. We'll get some more practice with them. Fluidotherapy, we'll show some example, show what that is. We're not going to turn it on. We have paraffin. Paraffin is here. It's all it is wax that we get to melt and then get to melt it in one of these crock pots here, and then we get to play with it. Anybody go to the spa and get manicured? Yeah. Yep. Yeah, that's it. That's all we're doing. Yeah. Part of well, we'll talk about paraffin in a little bit, but yeah, we're using it to heat. One of the additional things it can do is it can soften the skin, and for some conditions that might be the benefit we're looking for. Others, it's just the heat exchange we're looking for. So why would we use paraffin instead of a hot pack?
It conforms to the skin better. Sorry.
Say it. Yeah. Do you think a hot pack for 3 sprained fingers? Like if I slid into second base, sprained 3 fingers, do you think a hot pack is going to really work for that? No, irregular shape. I can't really contour it. So that's why I would use something like that. Warm whirlpool, we'll talk about as well. Infrared lamp, we'll talk about. We're not going to show it. Other types of deep heat that we'll talk about next week: continuous ultrasound and shortwave diathermy. Goals: alleviate or manage pain, reduce muscle guarding or spasm, increase tissue extensibility, and increase circulation. We've talked about that all in the pain cycle, all different aspects of that pain cycle we're trying to target with this heat. So. Yep.
So it's not actually good for the muscle. Or you just kind of like save time by stretching more. Actually help the stretch.
That's a great question. So does the heat help the stretch if the penetration depth is only 2 centimeters, or we're not actually penetrating the tissue, we're stretching? Great thought. I do think that for some people, stretching, is it fun or not fun? For some, I mean, for people who are tight and it's a big problem, it's not fun. So when we add this superficial heat, even though it's probably not hitting the tissue we want it to, it is a non-painful stimulus. So if we introduce a non-painful stimulus, could we push the bounds of that stretch a little bit better or hold it for longer because we're adding this non-painful stimulus? I think that's probably where we're truly working on it and not actually making a thermal change at the tissue itself. The better thing is, hey, you want to stretch your hamstrings, ride the bike for 20 minutes. Great. Now you're warmed up. Your tissue is warm because there's added blood flow to it. Now we can really stretch it. That's probably the best thing. Although for most of our patients, would they rather sit there with a hot pack or ride the bike? Sit there with a hot pack. Yeah. Yeah. So, yeah, good thought. Good question. All right. So some physiological effects of heat or, oh, what happened here? Increasing blood flow, increase the metabolic rate. So it can be beneficial when facilitating tissue healing, but it also can be harmful when there's acute inflammation and definitely infection. So those are reasons we would be either contraindicated or use precaution for it. One kind of out of the box application of heat that we could say, so we wouldn't want to apply a superficial hot pack to an open wound. We do have some other modalities we can use to open wounds. But if we thought like, wow, maybe they have contraindications that makes these other things that we could use contraindicated, but we got to do something. There's not enough blood flow here. If we have a wound kind of mid-thigh, for instance, well, we don't want to put hot pack over that open wound. But if we put hot pack distally at the knee, what's going to happen at the knee? We're drawing in more blood flow, right? Where does it have to pass through first? The area of the wound. So sometimes we can apply, like that's kind of an out of the box thinking where, okay, well, we don't have any other options. We can't put this over the wound, but if I put it distal to it, I'm going to be generating blood flow through the area too. So that's one of those out of the box thinkings of it. So again, the penetration depth is roughly 2 centimeters from the skin surface. Maximum temperature increases and is reached within 6 to 8 minutes of the application, maintained up to 30 minutes after the application is removed. Should be applied for about 15 to 20 minutes for maximum benefit. If you wanted to, if you thought, okay, we need to reduce muscle spasm, we'd apply this heat when the tissue is on slack. If we want to increase the tissue length, like what Sarah was saying, we can place it when the tissue is on stretch, and that would help as well. Anytime we want to increase blood flow, that's an indication for us. Contraindications, acute inflammation, existing fever. Again, that's a sign of infection, so we would want to stay away from that. Malignancies, cancers, acute hemorrhage, peripheral vascular disease, thrombophlebitis, blood clots, and radiation, usually with cancer treatments, that's unhealthy tissue to begin with, so we can't. Introducing a heating element can only damage the skin even more at that point. We don't want to. Some precautions during menses for women. Again, I've only seen this in one textbook. None of the other textbooks I've seen has this as a precaution. So keep it in the back of your mind. I've never run across it being a problem, but some women have trouble regulating their body temperature during their periods. And if that's that patient's one of yours, then I would say, okay, well, then we don't have to do hot pack today. We'll pick it up again next week when we can. So, Presence of sensory deficit during pregnancy is a precaution. Again, I'm more sometimes, most of the time, pregnancy is a contraindication for a lot of our modalities. For this, it's a precaution. I think area matters. Exact location we're using it. Edema, if we do have edema, it's after 72 hours of the initial injury though, and we think, okay, this person, I think heat is the best modality for this person. We want to make sure that we're elevating at the same time, because that's going to give a chance for that edema to escape. If we have that edema in a dependent position and we're applying a hot pack to it, we are potentially making the problem a lot worse. So we just want to, we can do it. We just have to make sure that it's elevated as we do it. Cardiac insufficiency, we're going to increase the cardiac demand. If we put hot pack on somebody, the body's going to deliver more blood flow to that area, which, where does blood come from? What's in charge of percolating the heart? I'm circulating the blood. I already gave it away, right? The heart, right? So just because of that, if somebody's has some cardiac insufficiency, that is, we really have to wonder. I have a hard time envisioning when that would come up. Like, hey, you had a heart attack yesterday. Wow, how you feeling? I got a hot pack for you. Choose that. But in our pathophysiology course, we also have massage students in that class. Well, massage therapists are also employed by hospitals. So I think that is something that the massage therapist probably needs to think about. They're coming in and adding a therapeutic benefit to somebody who had a heart attack yesterday. A massage might feel really good, right? Just say, hey, relax, I got you. Let's just relax, have a little fun, relieve some of that stress. I bet you that probably comes up more in their world in that acute setting than probably for us. Yeah.
I'm also on with blood thinners. Would that be like a contraindication?
I would probably think it's a precaution than anything else. But again, you as a clinician, you always, like, the textbook's job is to teach you the textbook stuff, and your job is to apply the textbook to all of your patients. And sometimes the answer is not right there. That's one of the reasons why we do skin checks after 5 minutes, just to see the integrity. And especially if the next time they come in and we see abnormal reaction to it, then we'd say this didn't go well. I'm not, whatever it might be. And blood thinners are a great question about that. Yeah. We don't want to do it over an open wound like we had just said as well. All right, so the hydroculator, that's where the hot packs are submerged in that hot water. It's going to deliver superficial moist heat via conductive heat, so in contact. They use some sort of silica gel. One of those hot packs are going to break at some point this semester, or at least in your first outpatient clinical, something's going to break. They look like just a clay that comes out of it. Usually the indication is that the water is cloudy. All right, one of these hot packs broke, the water's cloudy here, so got to look at it. What should happen if you found a hot pack that's broken? If you found the water's cloudy, what should your action be?
Drain the water.
Yeah, so clean the water would be a good step.
Maybe unplug from the heat.
I don't think, I mean, in order to clean it, we'd have to unplug it because we don't want the heating elements without water. But yeah, I don't think we have to discontinue use of all the hot packs. We just have to find the broken one and then get rid of it. Because you guys played with it before, it's got those canvas coverings to it. So that silica gel is heating up a lot, but that canvas covering is containing some of the heat. If that gel comes out and comes in contact either directly with the covering, or if it's bad enough leak and it comes directly into the patient, that is going to create a what? Burn. And what's the number one injury is burn. So we have to prevent that anyway. So anytime we have cloudy water, we got to find the broken hot pack. If we find a broken hot pack, sometimes you take it out, plop it down, and you say, oh, this stuff's squirting out. All right, well, we got to get rid of it. Can't use it. Did you have something else?
Yeah, in case where how long it's starts to rust at the bottom.
The hydroculator rusts at the bottom. Oh, that's why we hire aides to clean that stuff. That's why I'm the hand therapist sitting at the table playing with a bunch of marbles, and I say, who's the aide? Get cleaning. Yep. But guess what? Once you graduate, you become licensed. Now you're the PTA. Guess whose job it is? Yeah, exactly. Yeah. Yep. All right. So those have thermostats to it. So the water should be up between 160 and 174 degrees. That is one of the things you need to know. That's going to show up. It's going to show up on your licensure exam. It's going to show up on one of my exams. So that is one of those details that you do need to know. It's up to all of us to make sure that, I say all of us, anybody who's employed in that clinic, their job is also to make sure that the safety of the clinic is there. So pathways are clear. There's no trip hazards. The rugs aren't coming up and going to be a trip hazard. And also it's everybody's responsibility to make sure that the water levels are appropriate and the water temperature is appropriate in the hydroculator. It's not just one person's job. So if you apply if that thermostat breaks in the hydroculator and the water's way too hot and you apply that hot pack to somebody, well, it's your job. It's not Larry who's supposed to check it every Monday. It's your job. That was part of your responsibility as well.
That's something that's recorded in clinics.
It should be. It should be.
Yeah, we have a log and we have to put, temperature on.
Yep.
They usually have to do that during the night.
What's that?
Oh, it was too hot.
Yeah.
And then I'm like,
Yep. 164 degrees. What are you talking about? It's too hot. We can go up to 174.
you know what I mean though?
Yeah.
Like,
Yeah. Again, it takes between 20 and 30 minutes in between uses to reheat. So one of the problems with busier clinics is hydroculators cost money, hot packs cost money, and what do business owners not like to spend? Yeah, money. So we could have a busy clinic and then we could just say, well, we're just going to keep going with that. Well, again, it's one of those things where the therapeutic benefit, if we're only maximum penetration is what that depth for superficial 2 centimeters. So 2 centimeters is kind of like best case scenario. So if I'm using it every 15 minutes instead of 20 to 30, what do you think my penetration depth is? A lot less, right? Because we're not even getting to the right temperature. So yeah, I think that's another reason why I don't like modalities, but I think there's some user error that could go wrong there too. Everybody already knows this, but very important. Starts with 6 layers of towel, 8 layers if the hot pack is underneath of that patient. I know the PowerPoint says it's in supine, but anytime the hot pack is underneath of that person. Commercial cover counts as 2 layers. Brand new ones, we can consider the 3 layers. That's okay, but they're going to break in really quickly after. If it's a busy clinic, really after that first week, it's probably a lot closer to 2 layers than 3. So that doesn't last too long. So decreased effectiveness, if it's frequent use, like we were just talking about, low water levels, faulty thermostats, damaged packs. Good things about it: inexpensive, readily available, slow progressive heat delivery. It's not like coming in contact with something hot right away that could be jarring or create a burn. This is a nice and slow progressive release. So there's a lot of good things to it. Cons, it's heavy. How many people thought when they were playing with it last class that it was just like, especially around the shoulders and necks, where they thought like, wow, this is heavy? Anybody feel that? So if you had a big neck strain and then we put this hot pack around your neck, how does that feel? Potentially that weight can be irritating, just the weight of the hot pack. So maybe different positions would be okay. But yeah, that's a consideration for it. Might not conform to the body. We saw that last week. I would say get into a good habit of always using an extra strap to make sure that 1, it stays in place, but 2, we're actually contouring and coming in contact with the body. That I think is good practice to use, just using one right away. Anybody in the clinic that just uses them all the time? No, added straps with the hot packs. No,
Usually the ice baths full of ice.
for ice,
Yeah.
not a lot with these though. For ice packs though, generally you're using these?
Yeah.
Yeah,
No, usually it's big. Well, it just depends if it's on the shoulder.
yep.
So the big one.
Stay there, it's typical, and then it doesn't have, the pillowcase doesn't have like.
Yeah, the cervical coverings have that little piece of Velcro and the longer string to it, so you can kind of use it that way. I would get in a good habit of just using extra straps. Like for me, part of the setup would be, okay, get it ready, get out of the, hop back out of the hydroculator, put in the covering, get the number of towels, grab a strap, and now I can go to my patient. If it's not contouring, I use it. If it does contour, great, I don't have to use it, but at least I'm ready to use it. So part of the preparation, one, what's the proper position of the patient, including draping? How long is our patient going to be here for with a hot pack? Between 15 and 20 minutes. So we want to make them comfortable. I mean, the reason we're doing this modality is the number one reason is to manage pain. Are we going to do a good job managing pain if we put them in an uncomfortable position for 20 minutes? No. So let's make sure they're comfortable. As little as I care about my patients, we're doing the opposite thing. If they're uncomfortable position, we're applying the hot pack, we're defeating ourselves. So make sure they are comfortable. Make sure we do a good skin inspection. C triple T me plus sensation. Do you feel this? Yes, good. Assess sensation, heat tolerance, clear area of jewelry and any clothing potentially could be in the way. Pair the hot pack with toweling, give the patient bell on a timer. Timer one, make sure that, I mean, we're all busy. We all have other things to do. So it's really easy to have 5 minutes go by and me just say, no, I gotta get one more note done. No, you have to go check on the patient. That's the importance of that bell to make sure that we do, or the timer to make sure we do it. And there's timers for me to make sure yep. And then the call button, there should be some sort of bell or call button that they get to use. Because if they're now uncomfortable in their position, if they are experiencing maybe too much heat, it's uncomfortable. If they forgot to tell us to have some sort of muscle rub or ointment that's now reacting to the added heat, that, yes, there should be some sort of call mechanism to us, especially if they're in a weird position, side lying, pillows everywhere with big straps on everything, prone with hot pack on their back, like they can't move, right? So there should be some sort of mechanism to call us. Instruction of the patient, the education of the patient, warm, not hot, monitor initial response after 5 minutes. Textbook says between 5 and 10. Most textbooks says 5. I think 5 is always better. If there's going to be a problem, I'd rather catch it earlier than later. We can adjust the towels if necessary. So what Sarah was saying earlier is, what if I came back in 5 minutes, the patient says, no, it feels great, but I start seeing like I'm not comfortable with how the skin is reacting. I would add an extra layer of toweling if like safety is always more important. I'd rather go for a little bit longer. If I was planning on a 15-minute treatment time, I'd rather add an extra layer and go longer than let the skin just say, oh, the patient said they're fine. No. Yeah, they're fine now, but then we give them a burn, they're not going to be fine. So always be careful. All right, make sure we're checking the skin. So we have to check the skin before, we have to check it during, and then after the completion of that modality, we have to check the skin again. So we're checking the skin a whole bunch. Document that you provided this, that you did perform the skin check, what location, what patient position, how much time did it last, educated the patient on, what'd you say, pick, precautions, indications, and contraindications. And then there's an example of how we would do it. MHP. Yeah, so there's a lot of abbreviations for hot pack. I usually just go HP. MHP moist hot pack is another one. Any others that you guys see clinically? Those are the two major ones. Anything else? Just HP. Yeah, I've seen those are the basic two big ones.
Are the aides just preparing the hot pack? Like, you're not putting it on, you bring it to your PTA?
No.
Okay.
Yeah.
Curious, I'm sure it's different in every clinic sometimes.
Yep. That's the common use. That's pretty much how you guys are operating, right? Here's the problem with that though. If something goes wrong, to the aides, what happens to the aides?
Probably just smacked on the wrist.
Nothing. What happens to the PTA or the PT? I mean, that's against your license. That's against your malpractice insurance. If somebody gets injured, you're the one that's supposed to be in charge. And what kind of supervision do aides? We need direct supervision. That means line of sight. So if they're not doing the appropriate thing, that's why that's that type of supervision. It's always on us. Whoever us is, it's always on us. So I think because of its slow progressive heat, I think the risk of burns is pretty low. And especially if we have good training for our staff that say, okay, this is a big problem. But it's the number one source of injury for our patients is burns. So I wonder if there's a lot of places that don't give their aides enough education and the safety of like, this is actually, how many people got this level of education as an aide? So that's a little nerve wracking, even like day one to say like, okay, you're going to be, how many people as an aide would you say that's mostly what you do is applying hot packs and cold packs? And then yes, you can clean and fold towels, but that's big chunk of your job, right? So why wouldn't we educate you to this level of saying like, okay, this is going to be most of your job. And this is the most dangerous thing you can do is apply a hot pack to somebody. Why would we not spend an hour and really explain why? It's a little head scratching to me, but no, but I think when you are the PTA and you have techs and aides working underneath of you, whose responsibility is it that they do their job well? It's yours. It's yours. Yeah. If you've got your 12 o'clock patient and you're having the aide put a hot pack on somebody, if something goes wrong, it's on you. It's not on them.
Am I sitting here with the patient doing things while you're getting that hot pack? Are you coming back and I'm taking?
It depends on the facility. It depends on the schedule of the facility. It depends on who you're working with and the patient itself. It also depends on if your patient before them showed up late and you're running behind. There's a lot of things that are on play with that, but you are the one that's responsible. If somebody applies a hot pack to your patient, you're on the hook if something goes wrong. So all I think we have to do is educate our techs on how important this is, even on who made the mistakes last time on just having the towels folded the incorrect way, and there was just little pieces of the hot pack that were, yeah, we had 6 or 8 layers, but there was just one little section that didn't have any. That's all it takes. So yeah, it's on you if something goes wrong. It's not on the tech, even though they're the one that did it. Yeah. All right. Any other questions? All right, so we had a question on the added strap. So adding an extra strap to the hot packs of it. I always think you should have a strap ready to apply to your patient, because one, what we saw last class was that when Kim had it, she had to always readjust it. It kept sliding off and she had to constantly readjust it and hold it in place, right? Either do a shoulder shrug to hold it in place, have the other hand hold it in place, pick it back up. So if our goal is to provide non-painful stimulus, if she does have a shoulder injury, upper trap strain, Are we getting non-painful stimulus if she constantly has to do this kind of maneuver? No. What else is important about, because of the type of heat we're applying to our patient, we must have what? Yeah, for safety, we need layers, but we need contact. We're not just we can't hold the hot pack near the patient and say, no, you're gonna get hot, right? So we need contact. So part of the problem with hot packs is that it poorly contours to the body. So having a strap increases the amount of contact to the body as well. So, which would then decrease the amount of fidgeting that the patient has to do or guarding to hold it in place. Yes, they're now the patient can relax because it's added reinforcements just to hold it in place. So the holding it in place and not having a slide around and the increased contact are two reasons why we should probably be using straps more often than we do. When you guys that are techs and aides, when you guys go to work, just kind of like look around and say, like, could we have used a strap for that person? Would that have increased the contact or had the patient relax better?
Josh, my favorite example of that is you're like through the clinic and all of a sudden you see a person sitting in the chair with it on their shoulder and it flops on the
Yeah.
ground. You gotta stop and put it
Yeah.
back on.
Yeah.
You know, in that strap, that happens constantly.
Yep.
Does the strap change anything? Like, does it increase the heat? Does it?
Well, it's going to increase the contact.
Yeah.
So if we're increasing the contact, we're going to increase heat exchange, but it's not going to do it. It shouldn't do anything as far as like the time or number of degrees or anything else. It doesn't count as a layer. And what we had said earlier was if the clothing's in the way, we should remove it. Most outpatient places that I see has t-shirts and shorts for patient use. Extra stuff. You say, oh, I just came from a meeting. I'm in my suit. Okay, well, here's t-shirt and shorts. We'll wash them with the rest of the laundry. Do you guys have that stuff? Yeah. How about at Papa's? I know at OPT we do, right? So, and then in inpatient, we got Johnny's. Hey, you don't have, all right, good, here you go. Yeah. The patient shorts, they're not just the baggy, like one size fits all, yeah. Yep. All right, so here's what I want to do next. I want to get some practice. Let's go through our procedure. You guys came up with perfect procedure earlier. Let's go through our perfect procedure. Last time we were just messing around with, hey, how does this position look? How does this position look? Let's get it perfect now. Let's go through our perfect procedure, our perfect screens, our perfect education and conversations. Pick two of these: cervical, shoulder, upper back, traps, rhomboids area, lower back, and hip. Pick two areas and apply the hot pack perfectly. Okay. All right. Let's spend some time doing that. All right. Let's come on back. Let's see if we can talk through a couple of things. So I had a good question. Jonathan had asked for low back, what patient position would be the best? What do you guys think? Low back patient position. I think seated is good, prone is good. Yeah, unless they're pregnant. Yep. Yep.
You look comfortable.
What's another position? Supine, what do we think of the prone position just overall? Like, do our patients enjoy the prone position for the most part? So if we are going to be in the prone position, can I move this to low back? So if we are going to be in the prone position like Kyle is, and do you guys see what they did too? They added a little weight here just to make sure there is plenty of contact with. So that's a nice little thing too. what should we do if we're gonna hang out, and how much time again for the prone position? About 20 minutes, 15 to 20 minutes. So what I like about it is that I can, at my 5-minute marker that just went off, I can check the skin real easy. How long is it gonna take me to check the skin? Remove the hot pack, check the skin, go back, done, right? Patient tolerance in the prone position though, what do you think?
You have difficulty breathing, yeah, probably.
Difficulty breathing, pregnancy, tight hip flexors alone are enough to make me not like this. So how could we make it better? If we had to do prone, because prone is great, how could we do it better? Pillow, maybe even a bolster, like something like underneath of his pelvis, at least a pillow, maybe 2 pillows if they're really flat pillows. But yeah, we can modify that position so we can be prone but tolerable. Some tables have little arm cradles to it that you could put your arms into. Some people, it's just their shoulders. Their shoulders can't tolerate, go back to where you were. Their shoulders can't tolerate that position for long. I have problems with my shoulders in that position for long. So,
So if you did a supine, would like the lordosis like?
all right, Jonathan, this is what I want to see. So you had this cervical pack, but you said you were lying down on it. Go ahead and show me what you were doing. Good. And if we had anybody have an extra pillow around, we'd have an extra pillow and say, okay, oops, sorry. There you go. Make sure he's comfortable. What do you think about that? Jonathan, that's good. Great. We could bend his knees too, right? So if he wanted to, we could bend his knees. I don't like the cervical pack for this. Why? Why don't I? Not a large area to cover, although, you know, he doesn't have a lot of area to cover. So maybe it is okay for him. But yeah, in general, I want the more area I can cover, the better. All right. What else? What else don't I like about the cervical? I don't care about that for now.
Could you put a trap on it just to?
If we wanted to really, you know, suck up the sides, maybe we're trying to get obliques, or maybe we're not getting to a quadratus lumborum, but yeah. Absolutely. Look how much acute, like lumbar lordosis we're increasing just because of the skinny pack versus if we had the square, now that we don't have that focal kind of point pointing into them. So that's another reason I don't really like the cervical with the supine position. I think if we had a lumbar square, it'd probably be more comfortable. Now, what's the other downside? I got to come back in 5 minutes, and then what? I got to do a skin check somehow. So he's got to move, and especially if he's got a painful back, does he want to roll over? I mean, move, like, so there is some consideration for that stuff. Although if they really enjoy supine, oh, we'll do it, no problem. Roll over, let's do it. Okay, roll on back. It's not that big of a deal, but seated. What do you think about seated? Yeah. Because you're not wearing it, having enough layers. Is that why? Are you?
If she's seated, she has like the pressure.
Well, that's a great question. I would, because especially with you having the pillow behind you, where's the heat going to go? It's basically going to go into the pillow and then into you. It's not escaping into the air. So I probably would do it that way. Any good or bad with the seated position? Most of the time it's comfortable. Low back pain, does low back pain ever get worse because of a seated or flexed position? Yeah, so it is still patient specific. Yep. What else? Maybe some posture. Yeah, I got plenty of people where you say, golly, if you showed up 10 minutes earlier, we might get up on this table, but you showed up 10 minutes late, and we're not going to waste time just getting up here. Definitely. Skin check, what do you think? Yeah, just lean forward. I could probably do a good enough job with just leaning forward, although if that hyperflexion position is either difficult because something is in the way or painful, then that might cause a barrier. But yeah, all these things matter, right? What's the number one thing we're doing when we're applying a hot pack? Not adding a non-painful stimulus. So what's the penetration depth again for superficial heat? 2 centimeters or so. So do you think we're actually in Kyle's position there? If he's got a rhomboid strain, do you think we're actually, I mean, he doesn't have a lot of adipose tissue. So, you know, we're not just heating adipose tissue on him, but do you think we're actually getting to the rhomboid? Rhomboid, deep muscle, traps in the way. I don't think we're actually, I don't lay there for 2 hours. I don't think we're heating the rhomboids. But he's got a rhomboid strain. I want to use a hot pack. So because it's a non-painful stimulus. So what I want to have happen, anytime I'm applying something for the non-painful stimulus, I want that experience to be comfortable and non-painful. If he doesn't like the prone position and I say, no, this will be the best because it's easiest for me. If he's uncomfortable, am I actually adding a non-painful stimulus? No. So what am I doing? The penetration depth isn't deep enough to the target tissue that I want, and the position's uncomfortable. Did I actually do anything in that 20 minutes? I just wasted 20 minutes. I got some notes done, you know, but yeah, nothing. So I think the patient comfort is the number one thing we have to consider when we're applying these hot packs, because that's the number one thing we're doing is adding a non-painful stimulus. Does that make sense to everybody? Anybody play around with the straps? What do you guys think? Like helpful? One other thing I wanted to clue in on, can I use your neck? So making sure, what do you really wrap this thing up, huh? I'm not judging you. Did a great job. So we've got the kind of peak end, the convex side of this. What are some times would we want to apply this to somebody's neck with that convex side pointing up towards the ceiling? When we're trying to heat the suboccipitals. That's the only time we really want this pointed up. What has to happen though is we have to, as we're contouring this around the neck, there's a little gap between the hot pack and their suboccipitals. So if the number one thing we need for this type of heat is contact, I've lost that here. So that's where those added straps can come in really handy, especially for that. The only problem with the hot pack pointed up here is it, as I suck this in, watch what happens to his head. Where does it go? It's kind of being forced forward, right? So if we have muscle guarding, if we wanted to decrease muscle guarding, the hot pack should be placed when the tissue's on what? Stretch or slack? Slack, what's happening as I push this forward? It's on a stretch. So we have some considerations where is this the right position to be in or not? Maybe supine is better. Okay, but now we're on top of it, need to add 8 layers. So there's a lot of things that we have to consider. Anytime, because of that forward head position that we create when the hot pack's pointed up like this, the only time it should be pointed up like this is when we're targeting those suboccipitals. Every other time, if somebody's got a hot pack around the neck, we definitely want to point that down, because look at that. Isn't that incredible how just the orientation of hot pack changes the orientation of his head position a lot? Plus, it now targets the entire length of the cervical spine, including the lower cervical and upper thoracic. So important to understand just the orientation of that hot pack too. All right, any other things that you guys came across that was? Yeah, we want it covered, yeah. Yeah, we just. Yeah, if you want to do it that way, you could, yeah, yep. All right, so today we're going to talk about paraffin. It takes a little bit of time for it to heat up, so we're not going to be able to play with it today. We'll play with it on Tuesday, yeah, today's Thursday. Thank you. So paraffin, if you've been to a nail salon, you've probably seen paraffin. We can use it therapeutically, so conduction heat transfer. With a paraffin wax and mineral oil. So if you guys want, here's the paraffin wax. It's in this bag. We would take it out of the bag to then use it. So you guys can just look at it. After some use, it gets a little softer. Here's what it looks like in its crock pot. So the temperature of the paraffin wax should be set between 117 and 130 degrees. Best suited for distal extremity joints, hands and feet are the best uses for this. Conforms better than hot pack. That's really the big feature we would want to do this with. So I think, you know, you guys are learning so much, not only in this class, but also Patho and any other classes that you take. I think some of the study tips I have for this is, we talked about it in PTA 1, like keywords. What does non-blanchable mean? Stage 1 pressure ulcer. I mean, that's a key word that's attached to something. Like anytime you see non-blanchable, you just automatically think stage 1 pressure ulcer. And then you go to a cooking class and they say to blanch something, and you go, I thought, what are you talking about? I think sometimes when you're studying, there's so much material, not only in this class, all of the different modalities. Why would we use one versus another? I think one of the key words for paraffin is hands and feet, like irregular shaped joints, distal extremities. I think that's one of those things that, you know, in an exam question or in a practical or with your patients, hands and feet paraffin are best. Not everybody has them. Have you guys seen, do you guys have hand clinic, you have OTs? So they probably have this.
I haven't seen it
You
yet.
haven't seen it. Yeah, ask if you have it next time you're at work. I bet you they do. You always see it at the nail salon. So if you're going to open up your own practice, just make sure it's next to a hand salon, a nail salon, and say, hey, can I borrow your paraffin? Have you seen it? Yeah, you do have paraffin. How about you guys? Have you guys seen it? Yeah, nice. At the outpatient place I've worked at, we never had one. So they might have one now, but never had one where I was at. Can, yeah. So next time we'll play with it. It's pretty fun. So what this wax, anybody ever make your own candle? In second grade, I made my own candle. You dip the wax and you let it cool and you dip the wax again. You got a bunch of layers. That's all you're doing here with this. So you can, I'll call up Mrs. Leach, my third grade teacher. Oh yeah, did you have Mrs. Leach as well? Good teacher. Oh, maybe she moved. Maybe she's the same one. So there's a couple of methods for it: dip and wrap and dip and immerse. So the dip and wrap is the patient submerges their hand, then pulls it out, and then they do that again. They do it between 8 and 10 times. That forms like a glove around them. And then what you do is you wrap it in a plastic bag and then a bunch of towels and then a bunch of elastics, and you just get to all of that extra insulation is just keeping all of the heat in there. It's best if we elevate that to prevent edema. So whether it's with pillows and holding the patient like this, I don't know of many patients that like to just sit with their hand up like this at all. How do you like to do it? Do you? Okay, yeah, so kind of a ramp so that, yeah, that's a good way to do it too. The other one is dip and immerse. So again, it starts out the same thing, 8 to 10 dips, create that glove around their hand. And then you just leave it in the tank. So that's the other way to do it. Big thing with that, we have to ensure that that wax glove that we just formed doesn't have any cracks into it, because then we're increasing the tissue, the temperature of the wax in that one focal area, and that can create burns. So I don't see, I think most of the time I see the dip and wrap method for that safety reason. Any thoughts on that? You guys that have had it done to you at the nail salons, any difference in techniques?
No, they just put a plastic like glove, like a, basically looks like a Ziploc bag, but like glove.
So you put the glove on, so you put the glove on the hand and then you dip it in.
Yeah.
Yeah.
They do it like, well, like you dip it and then it's the glove on and you dip it. And then you just sit there for like 5 minutes, leave it, and then pick it up.
So the glove is nice because something like that. There's the glove. Here you go. There you go. So that's nice because when in the nail salon you have community wax, it's just going to keep the wax free of anything that got on there. But yeah, that's all it is.
So you can leave your hand in the tank of wax.
Yeah. Yep.
Well, of course, we're gonna be washing our hands and taking our jewelry off, just like we do, so we try to keep it as clean as possible sometimes. Then, you can just, when it's liquid, you just dump it out. You just have to be careful when you dump it. And it's messy, like hard to clean because there's mineral oil in the wax. It gets stuck everywhere.
Just kind of gives me like.
Yeah.
There you go. That's a picture of the glove, that wax forming. This one. Yeah, there you go. There's a little bit of one. You can see there's where the dip line was. So there you go.
Those are used often, the waxes.
Say it again.
We use that often.
I've never used paraffin therapeutically, or I don't run a salon either. So I've never, the only time I've used paraffin is in this building here.
Yeah.
The next time I'll use it will be next year when I teach this class again. So I don't.
I didn't use it much either, but I think in a hand clean, you know, like once you get the wax on, then you can like do a lot of exercises to get it off.
Yeah.
So you can like use it, you can use it for exercise too, so, but it is messy, hard to clean, like, you know.
Yeah, if there was an irritation, it takes so long to get it out, right?
Yep. You peel it off. Yeah. Yep.
It's like almost like it's almost like Play-Doh.
Yeah.
Much
Yeah. Thinner Play-Doh that you can. Yeah. Yep. You ever like peel glue off in elementary school? Yeah. Same thing, a little thicker than that. Yeah. So it is nice, like what Tony was saying, if you are a hand specialist or if you see a lot of hands in your clinic, then this is a good tool to use. The other reason why it's nice is if someone has chronic hand problem, hand arthritis, they can buy a crock pot and some wax and they can do it every single day if they want, you know, and they can manage their symptoms at home with it. And we just teach them exactly how to do it. So that is really nice. It's fairly inexpensive for those chronic conditions. There is a hybrid application that I don't know if you've ever seen this before. Cycles of 2 minutes in, 4 minutes out. So you submerge for 2 minutes, then you let it kind of cool for 4 minutes, then you put it back in for 2 minutes. Seems like too much time for me. But if I'm behind on my notes, you say, hey, we're going to try something different. This is going to take us 45 minutes.
But it seems awkward to like your hand in that thing. Could you take it out and then?
For the dip and immerse technique,
Yeah.
yeah. You don't need a hot pack on it because once we'll play with this on next week. Once you dip and then if you wrap it, all of that insulation, the plastic bag and the towel, it keeps that heat in. You'll be surprised how much heat is delivered into the hands. Yeah.
Like I feel like everyone would rather dip it and then take their hand out of it than do
I don't know why someone would choose dip and immerse versus dip and wrap. Maybe that's a question you can ask a hand specialist. Yeah, yeah, maybe you don't have the supplies to do it. Yeah, yeah. Yep.
And we would look for like cut with scrapes.
Yep. Skin screen. Yep. Absolutely. Skin screen, jewelry off. Absolutely. Yeah. All of that. So here's our real jewelry and clothing, wash and dry area, visual skin inspection, check sensation, heat tolerance, instruct patient what to expect. Avoid touching the sides and the bottom of the unit. That's the hottest area. So we'd want to teach our patient to avoid touching that area. And then the tricky thing is we can't check the skin during. We can check proximally, so if there's a reaction, if we start seeing a reaction proximal to where the dip happened, then we could assume that there's something wrong underneath of that wax, but you can't visualize the skin once that stuff's caked on. So that's difficult, but we would still want to do it before and after. After, why is after so important? Allergic reaction, what else?
Make sure that the skin peels off or something.
Yeah. So, I mean, we want to provide first aid if we need to, if there's a burn or something else. Also, if there's just a bad reaction, if we think like, wow, this is not what I wanted to have happen, next time, what are we going to do? Not do it. Yeah, not do it. So that's really important. So the pros of this, well, it's inexpensive, like we were talking about. Home units can be purchased easy, can conform to the area. Anybody, what's that show on NBC that the house burned down because of the crock pot? What was that show? What was This Is Us? Yeah, This Is Us. Yeah. So if you're a This Is Us fan, maybe this is a little intimidating to you. But the big benefit is it conforms to difficult areas like hands and feet. Con, unable to see the treatment area as we're providing that treatment. So that is one of the cons to it. Can't move during the treatment. We want to keep that hand still as we're having on us. So that can be tough. Really only exposed with heat in the first dip, and then it's just more and more insulation after that. So there's some concern about not enough heat exchange, and really only hands and feet. Document, we'd want to say we did the paraffin skin check, what method we used. I think dip and wrap is the most common one that we're going to use, but you're going to ask your hand specialist if we do anything, if they like to. They might say, we haven't touched that thing in years, and that would make me happy too. Document the education, contraindications, and precautions, and then also total treatment time as well. Do you have the Fluido? Want to wheel that out? Yeah, perfect.
I just wanted to add into that, when they go in, I lost my train of thought because I was thinking about food.
Okay.
All
right.
Sorry.
That's all right. So again, on next week, we have a couple of different of these units that we'll get to play with. 117 to 130 degrees. Yeah. Whose responsibility is to make sure that these are working and the temperature is appropriate? Everybody's, yeah.
I'm assuming the dip feet in there, so, like,
In the paraffin, yeah. The paraffin you're talking about, yeah. Yep. Yep. Let's see.
Yeah, Lauren loves that.
So our unit will show you our unit. It has to be cleaned and repaired. So not a good picture here, but we also have fluidotherapy. So we're gonna use convection heat transfer. What was that convection again? Air with air, some sort of circulating air. So what we're gonna use is a natural cellulose enclosed in a cabinet. We have corn husks. It's dry, warm air is circulated. It's controlled with a thermostat, temperature between 102 and 118. We also can control how much turbulence is in there. So we can have either a mild air exchange or we can increase the air speed and have more. So that's pretty fun.
And what is the corn husk do?
It's, yeah, and then that's what's going to help transfer the heat. It's dry. Nope, dries. Yeah, yep. So the machine heats up, the corn husk heats up, and then the air spins it all around. Now, what's good about this is different from paraffin. We can do exercise at the same time. So that's a real benefit to the paraffin over the Fluido. And again, I think when we start looking and start studying what are the key differences, why would we choose Fluido over paraffin? Both are good for hands and feet, not really anything else. So why would I choose one over the other? All right, well, if there's any sort of allergic reaction to any of the wax or anything like that, that's one. The big benefit, we can move in this thing where we have to stay still with the paraffin. The other benefit to this is there's no loss of heat during the treatment. For our hot packs, it's the first 8 or so minutes we increase in temperature, and then after that, we start losing temperature. For the paraffin, it's really the first dip we have good heat transfer, and then we start insulating, but we're basically losing heat the entire duration. For this, because it's plugged in and controlled, it stays the same temperature as long as it's on. So that's a nice benefit to it. It's a constant heat. Yeah, we can control the temperature. Yep.
Now, what would that, why would you choose paraffin over Fluido?
You tell me. Number one thing. Yeah. Yep. The other thing is, if you are the business owner, which one would you like to purchase?
One that uses less material.
Less material, less space in the clinic. I mean, if you're a hand specialist, which one do you think costs more? Just by looking at them. Yeah, it costs more. It's also louder. So if we're in a busy clinic like that, that's a consideration for it. So yeah, paraffin, cheaper. Wax disposable, we can get rid of it real quick. So there's some benefits of the paraffin over the Fluido.
You say you do exercise, so when they're in there, they like.
Free to move. Yeah. Either ankle, foot, hand, squeeze. Yeah. Whatever. We could give them a little stress ball as they hold it in there if they want. Yeah. So we can either use a bagged technique or a non-bagged technique. Bag technique is just what she was saying with the paraffin. You put a plastic bag first, and then you dip your hand. You put your hand in the paraffin, in the Fluido, or your foot. Or we could have a non-bag technique that's just without that barrier in front of you in it. The bag technique is we can use with wounds now. So that's a benefit. We can actually supply some heat with a wound. We just use the bag technique so it's not directly into the wound. So that's great. Non-bag techniques, more appropriate for providing heat and also desensitization. So because we're not having that barrier of that little plastic, as the corn husks are hitting the skin, that can be a desens. Anybody ever, I'm sure everybody's felt this way where, anybody ever get like really sick and even like the sheets on their bed or their blankets like is irritating and they say, I can't even take this feeling. It's not hot or cold. It's the feeling of this material against my skin I can't take. So that can happen for some people, especially I find with crush injuries. So if somebody, had a big weight crush their foot, crush their hand, something like that, the nervous system goes pretty haywire as the nerves try to regenerate. And it's that sensation of I can't have anything touch this at all. So one of the things we can do in physical therapy is a process of desensitization. Start with as non-aggressive materials as possible, silk, cotton, and then work our way up to more and more insulting materials. So this is one of the things we can do for that. I haven't had to do too much with it. I've had to do some, maybe a couple of times a year. I'll have someone who I say, wow, we got to do this technique. It's not all that common, but you'll see some of it, especially post-surgical. You'll see that happen a lot. So for fluido, we want to prepare a patient, remove clothing and jewelry, of course, wash and dry skin area, visual skin inspection, assess sensation, cover any lesions they might have with a plastic barrier. This is safe to use with splints and bandages, metal implants, plastic joint replacements. I don't know how many plastics I see, but also check the skin response to it. So again, we can't turn it on. It needs to be cleaned, and the husks need to be replaced. But at some point, feel free to look at it, and you can see what it does. So Pro is easy to set up. I mean, it's set up. You just got to plug it in and turn it on. It's ready to go. So that's not a. I think it's way harder. This paraffin wax. If you wanted to use it by 12 o'clock, you're too late. Can't. So it takes a lot of preparation. This thing. Nancy showed up. It's Thursday. She was supposed to show up on Friday. No problem. Just plug it in. We're good to go. Paraffin. You can't see it today. Thing's not ready. So easy to set up. Minimal maintenance of units. Control temperature throughout treatment, I think, is a real big benefit to it. Applicable for hands and feet. There are some different sizes. This is pretty much the standard size, but maybe we could get as far up to maybe our, just distal to our elbow. So you can cover more area than you can paraffin. That's nice. You can move during it. You can control the turbulence of that, how much air and how much those corn husks go flying. Stimulates mechanical receptors. That's nice. So as long as our patient isn't really sensitive to this, that constant airflow and the husks kind of colliding into that's non-painful stimulus. And that's all we're trying to do for mostly everything we do is non-painful stimulus, right? Machine itself is expensive. You got to replace the corn husk fairly frequently. And it creates a really dry environment around the unit, which sometimes is good, sometimes is bad. So. All right, and there's our documentation for that. Heat activated, air activated heat wraps. I bet you guys have seen some sort of version of these. Like I think a lot of people go hiking in the winter, grab these little hand warmers. Anybody ever see those? Similar to that stuff where it's just going to conduct transfer of heat. Disposable wraps. I don't see them used therapeutically a lot, but it's something we can provide to our patients. Say, hey, you really like heat. It's a great non-painful stimulus for you. Go get some of these, and you could do that with yourself. Because can our patients get hydroculator quickly? There are home units, but you got to find them and you got to maintain them. There are different microwave versions of hot packs that you could do even with the moist heat. Put them in water and do it. It's tough, right? These are cheap, easy to use, disposable. Again, I don't see them used clinically. I think the best thing that you could use for is the duration of time that you get to use it for. They get to stay hot for a handful of hours. Anybody ever use these? No, nobody's. How long approximately do you think they last for? Couple of hours? Depends.
Yeah.
Depends on how cold it is. Oh, okay. Yeah. You have the ones that stick, they have adhesive and they stick to, yeah, so that's a nice one too. Yeah. So again, I've never seen air activated therapeutically. Just one of those things you talk to your patient, say, hey, go pick this up. Yeah. We could look at infrared radiation, although it's clinically use is obsolete, so this is as much as I'm going to talk about it, so. I've never seen infrared radiation used for hot bath. Have you for heat for a patient?
No, not really.
Yeah. What's that? I don't think so. I don't know. Wand, I don't know what the,
Facial.
The radiation, the red light.
that might be laser. Is that what you're thinking of?
I think, remember, a long time ago, they used to use it was round and it heated.
Yeah,
They
yeah.
used to use it for heating
Yes, this is what I remember.
Because it kills
It was
bacteria.
like this thing where they would do it and then put the towel over it, they would move it, put it there, put the towel over it. and, like, block
Oh,
it.
that might, he might be right, that might be laser or light therapy.
That's what I was thinking.
There you go. What is that thing? Look at this guy. That's fun. All right. Well, I've already taken way more time talking about infrared radiation than I wanted to. So
Psoriasis.
I think that's what, yeah.
So, I think it's like a sunbox.
Yeah. That's what I recall it
Yeah,
being.
they
We have that.
Oh,
I
yeah.
have one. It's like a big ass thing, right? Sorry.
I don't know.
It's a picture. It's-
All right. Have your infrared conversations outside of class time. As much as I love going off course, I refuse to because of radiation. All right, we're gonna cover some thermotherapy. Hopefully we get enough time so we can just grab a cold pack. You know what, let's just skip all the way down to cold packs and we'll kind of do the same thing we did last time, is circle back to this. So cold packs stored in a freezer contain some sort of gel substance in it to hold on to the cold for longer. It remains cold for about 10 minutes. Needs to cool at least 30 minutes in between uses. So again, people who work in busy clinics, does that actually happen or not? 30 minutes in between uses. So anyway, we could use it directly over the skin. What we're going to do with our cold packs, we're going to use some sort of barrier like a pillowcase. Again, the risk is instead of burns, it's frostbite. So we do have to be careful. There's sometimes where we'd want to use a more intense cold, and we will learn that. But for our cold packs, we want to use a pillowcase. And the big thing you have to have is just like with hot packs, we need contact with the area. Now, because of this gel, the gel is going to be a lot more, I don't know, flexible, if is the right word. So it's going to kind of slide around a lot easier than the hot pack is. So we have to use an additional strap to keep it in place. One that's contact, two, it's going to keep it in place. We can reapply it every 1 to 2 hours. We want to give that time to break because we don't want to give any sort of or minimize the risk of frostbite. Our application time between 10 and 15 minutes. 10 minutes is what I would expect you guys to know and perform in here. We could use ice packs, crushed ice in a plastic bag with a towel, a little bit more aggressive than ice packs. We could make our own if we needed to as well. So here's what I want to try. So the contraindications to all cryotherapy, thermoregulatory problems. So if somebody can't control their body temperature, the initial 2 to 3 weeks of wound healing, cryoglobulinemia. That is a rare condition where the blood coagulates in response to cold. So somebody has that, you say, oh, really, you have that? Well, I'd love to do ice on you, right? Give you some blood clots along the way. Nope, can't do it. Or over regenerating peripheral nerves. Now, there are some people who just have an intolerance to cold. Those include Raynaud's disease. Anybody here have Raynaud's? You usually have one person. So Raynaud's is hypersensitivity to cold. The fingertips will turn usually pale. This is a real extreme version of it. And usually it'll subside pretty quickly once the response happens. It usually responds pretty quickly once that cold stimulus is removed, but it can be painful. We also have wheals. This is a hypersensitivity to cold as well. This wheals response. Other precautions: sensory deficits, impaired circulation. High blood pressure is one of the precautions. There's a transient increase in blood pressure when we apply cold. So that is something to consider. If they are already starting with high blood pressure, we wouldn't use that. Cold over a deep wound, cold aversion. So people just hate it. And over peripheral nerves. The peroneal nerve is the big one around that peroneal nerve with the fibular head. So what I want to try now, just for the remainder of class, is I want to try application of a cold pack. So the procedure we'll use, same procedure, indications, contraindication, precautions. Next week, we'll dive into more of the details here. I just want to spend the last 20 minutes with hands-on stuff. I want you to practice a bunch of different positions, just like we did with hot packs. Just mess around with positions of the hot pack. Can the person what do we do? Cervical, shoulder, elbow, low back, hip, knee, and ankle. I think we did those 7 areas with hot packs. I want to do the same thing and come up with a couple. Oh, is it right behind me? Is that what you're saying? Did I get them all?
Yeah.
Hey, all right. And come up with a couple positions of each and just mess around. Okay, if they're in this position, how would I secure it? Is this good or not? Definitely make sure we have our additional strapping for it. Okay, so ice packs are in the freezer. Make sure you have a pillowcase barrier and then make it strapping. And then we will cover the rest next time.